We'll be talking tonight about the acute management of upper GI bleeds. So tonight I'm going to be talking about various conditions that can cause upper GI bleeds. It might be worth going away and just reading up on them in a little bit more detail, because I'll be talking mainly tonight about how they're managed in the acute setting and how they're assessed. I can see there's lots of people watching tonight. So you might be watching from elsewhere in the world. So it's just to say that this is based on what we do in the UK and what happens in the NHS. So things might vary based on where you are in the world. So take that into consideration whenever you're revising this material. Okay, right. So what we're going to cover tonight. So we're going to start with an introduction about upper GI bleeds, a bit of etiology, so what causes them, their initial management, how do we investigate them, and what further management do we use. So a little bit of introduction. So an upper GI bleed is basically a bleed from the upper GI. So the upper GI system is from the ligament of Treitz, proximal to that at the duodenojejunal junction. So it's a bleed that happens anywhere above that point, the ligament of Treitz. It can be caused by multiple etiology. There's no one specific cause for it. I'll cover some of the most common causes later. And this is an emergency that you might come across in A&E. And it needs to be taken seriously because it's got quite high incidence, roughly about 84 to 172 per 100,000 in the UK. And it carries quite a significant mortality. So about 6 to 13% of all patients. Mortality is often due to hypovolemic shock due to lack of circulation volume. So something to take seriously. Yeah, so what type of things are we on the lookout for with somebody with an upper GI bleed? So they might have hematemesis. They might have coffee ground emesis, which is coughing up coffee ground. They might have melena. They might have a low HB that might be picked up on a FBC. They might be hemodynamically unwell, so they might be hypotensive, they might be tachycardic. Or they might have hematochezia, amongst many other symptoms. Just these are some of them. Hematochezia is bright red, brisk bleeding from the rectum, but this is usually only seen with really quite bad upper GI bleeds. So what's some of the important common causes? So there's three main ones. So peptic ulcer disease, so that's duodenal and gastric ulcers. Bear in mind when you're taking a history from a patient, always remember duodenal ulcers get better, get painful a few hours after food, where that's more immediate with gastric ulcers. Mallory rice tear or esophagitis. So those are the main three ones, but there are other causes. Some of these are a lot rarer than others. Have a look at them, especially gastric varices, AV malformations, tumors can cause it. So just familiarize yourself with a few of these terms. Okay. So key details to elicit from a history for patient with upper GI bleed. So you want to know about the bleeding initially, so how long it's been going on for, where are they bleeding from, how much are they bleeding, is it just a little bit when they cough, are they vomiting blood, is it a bit mixed in with their feces, has this ever happened before, have they got a history of GI bleed, are they on warfarin, anything like that. Past medical history, Do they have a history of esophagitis, dyspepsia, reflux, GORD, any alcohol history, and also drugs which might cause bleeds. So are they anticoagulated for some reason? Do they have AF in their history? Are they taking bisphosphonates for osteoporosis prevention? Are they taking NSAIDs for chronic pain? So I think these are things to explore in a history. So I'm just checking the chat. Okay. So examination, what do you want to pick up? So you'd want to get a full set of observations, and then potentially emergency setting, it's always good to have a full set of observations before you examine a patient. So this includes pulse, BP, temp, respiratory rate, SATs, and consciousness. So in all patients which are in an emergency setting, it's good to use an A to E approach. So if you find something critically wrong, you stop, you try to fix it before moving on to the next step. So we'll go through an A to E assessment of an upper GI bleed now. However, there is one caveat. If a patient is torrentially bleeding and it's considered maybe a massive hemorrhage, then you skip straight to the C, because this is the thing that's most likely to kill the patient. So you treat that first, but otherwise you use an A to E approach systematically. Okay. So A to E assessment. So let's start with the airway. So is the patient conscious? Are they breathing? If they're not breathing and there's no signs of life, you do CPR. So if the patient is awake, is the airway patent? If they've got if they're vomiting blood, that airway might be compromised. Can you secure an airway? Do you need help to do this? Head tilt, chin lift can be useful, jaw thrust, or you might need to use an airway such as an oropharyngeal or a nasopharyngeal airway to maintain the patient's airway so they can keep breathing. So those are the things you need to think about in airway. B is for breathing. So have a look at the chest. Is it expanding? Is it equal chest expansion bilaterally? What is their respiratory rate? You can get this from their observations, or you can have a look yourself. What are their oxygen saturations? Inspect the chest. This is the same procedure in all emergency settings. Have a look at the chest, see if you can see any bruising, deformity, things like that. And have a listen to their breathing sounds as well. These for circulation. So in the case of a GI bleed, a patient might look pale, they might have pallor, they might be tachycardic, they might be hypotensive if they've got particularly bad bleeding, capillary refill time. This is particularly important in bleeding. Their fluid balance, so you know, how much are they urinating? It's important in upper GI bleed patients to catheterize them so you can get an accurate assessment for how much fluid you're putting in and how much is coming out. An abdominal examination is also really important. So palpation first, are they tender? Are they guarding anywhere? Auscultating, see if bowel sounds are present. And also looking for a peripheral stigmata of liver disease that you might see coincidentally, like caput medusa, dilated veins, ascites. Elsewhere other than the abdomen, you might see clubbing, pulmonary emphysema, or gynecomastia. That's for liver disease, which is associated with liver cirrhosis, which it can be a cause of esophageal varices, which is a common cause of upper GI bleeds, which we'll go into later. Okay, so more on the circulation. Establishing IV access is a priority in these patients because if they're losing blood, they're losing their circulating volume. This needs to be replaced with either fluids initially or later, if it gets worse, a blood transfusion. So standard procedure, 2 large bore cannulae are put in to a patient. This allows reliable access, so you always have another port if you need it. And you can request some bloods. This is not an exhaustive list, but these are some of the important ones. So an FBC, looking for hemoglobin, MCV, UNEs. What are the UNEs looking like? Are they an AKI? Clotting is really important, as well as a VBG. And if you're thinking about transfusing a patient, you need to get a group and save and a cross match to be able to safely administer that. A lot of further management in upper GI bleeds is coordinated by seniors, such as consultants, due to the risk of accidentally giving patients a wrong blood transfusion. So always involve your seniors, always keep them involved. If you're doing an A to E assessment on a patient and you're concerned that they're seriously ill, you should have your senior with you at that point. So a little bit of a segue from circulation, we'll talk about ATLS hemorrhagic shock classification. So this table basically allows you to categorize how bad somebody's hemorrhage is. So as you can see down the side, you have a blood loss as a volume of percentage blood and in mils. Heart rate, blood pressure, respiratory rate, and urine output. You can see now why urine output is quite important, because if a patient has decreased urine output, it suggests greater hemorrhagic shock. And also, how anxious are they? Patients who are slightly anxious are grade 1, and then if they're becoming lethargic, then you know it's more serious, and allows you to quantify and sort of stratify how bad a hemorrhagic shock is. Yes, that's quite useful to bear in mind. Okay, so back to circulation. So hypovolemia is the term for low circulating volume. So if a patient comes and has the observations and they're hypotensive, fluid resuscitation is required in these patients. So this is standard 500 ml, 0.9% NaCl over 15 minutes. If a patient has risk factors for becoming overloaded, such as heart failure, things like that, this is reduced to 250 ml. And then whenever you give fluid to a patient, you always reassess the fluid status to see if it's made an effect. So you redo observations, you see what their blood pressure is, and you do a clinical examination. And this includes have a listen to their chest to see if they, become overloaded, they'll get pulmonary edema, and have a look at their JVP. Is the JVP raised? If a patient is needing significant amounts of fluid resuscitation, or you're concerned it's not having any effect, you need to speak to your senior and consider maybe potentially having a blood transfusion. But this decision is obviously your consultant or senior's decision. Yeah, so in an emergency hemorrhage, always go by your local guidelines. So you might have a major hemorrhage protocol, but activating that won't really be a junior's decision, it will be a senior decision. Okay. So yeah, check FBC. Does the patient have a low hemoglobin? That's an important point in circulation. Moving on to D. So assess the patient's level of consciousness. You can do this with the Glasgow Coma Score or very quickly AVPU. As I showed in the hemorrhagic shock classification, level of consciousness and irritation and lethargy is quite important for quantifying how bad a bleed is. So it's good to know that if a patient becomes really, the circulation becomes depleted, they can lose consciousness. So this is important to assess. In disability, in all A to E, you would want to do blood glucose, and you'd also want to do ketone levels. Okay. So exposure. So looking for peripheral signs. I talked about this briefly before. So So peripheral signs of maybe they might have liver disease, and you might see some signs of this elsewhere. You might see peripheral edema if they become fluid overloaded. Patient temperature is important to take. This will be done in your observations, of course. And it's really important with anybody with a GI bleed to do a rectal examination. So ask the patients to do a rectal examination to see if there's any bleeding from the rectum. Fluid balance is really important. So catheterization allows for you to be able to assess their fluid status a lot more accurately. Okay. So now we've done a quick A to E assessment. I'll talk you through how we score patients pre-endoscopy. So we use something called the Blattsford Score. This is used before endoscopy when the patient is first assessed. And it's used to assess whether intervention is required in a patient. So if they've got a low score, medical intervention may not be necessary. So those are the parameters that are included in the score. Blood urea, hemoglobin, blood pressure, BPM. Have they got any evidence of melena or syncope? And do they have a history of hepatic disease or cardiac failure? And you add these scores up, and I'll talk a little bit more about how you interpret the scores later on. But remember, Blattsford Score is done first. Okay. So in the UK, we use NICE guidelines, and these are basically the criteria for endoscopy. So if patients have a severe GI bleed and they're unstable, you would want to do an endoscopy as soon as possible. If the patient is not that unwell and they're more stable, you can do it within 24 hours. So management of upper GI bleeds in NICE guidelines is split up into non-variceal and variceal bleeding in the acute management. So variceal bleeding is what I talked about before. It's esophageal varices. And non-variceal bleeding might be things like peptic ulcers and things like that. So they recommend endoscopy, and they recommend 3 techniques can be used. So mechanical plus or minus adrenaline, thermal coagulation, or fibrin or thrombin plus adrenaline. Important point to make is no PPI, no omeprazole or H2A antagonist should be given before endoscopy. When they do the scope, they want to see exactly what's going on, and giving a PPI before that might affect what they see. If an upper GI bleed is found on endoscopy, and there is evidence that the patient has had an hemorrhage, a PPI is offered after that. People who are at risk of rebleeding, there is senior support is needed for consideration for repeat endoscopy, IR or surgery. So that really depends. That's more of a senior decision, but something for you to maybe be aware of, that a patient who has an endoscopy and you think a bleed has stopped, it could start again. So there needs to be a plan in place for what happens. And this completely depends on the service provided at the hospital you're at. Some hospitals don't scope overnight. You might not have somebody in IR that would be able to do a procedure. So in that case, surgery would be required, but this is obviously based on what hospital you're at. Another thing to mention is NICE recommends not using just adrenaline on its own when doing endoscopy treatment for non-variceal bleeding. It has, they say, in a combination with one of the 3 things mentioned there. Okay. So now we've talked about non-variceal, so we'll talk about variceal bleeding now. The treatment's a little bit different. So at present, if a patient has an upper GI bleed and there is a variceal cause, such as esophageal varices, then terlipressin is given. Terlipressin is a synthetic vasopressin analog, and it causes vasoconstriction in the splanchnic circulation, and it causes a decrease in portal pressure. Just quick, it would be a good thing to mention now that I think you should probably just look up the circulation of the portal vein system, because it makes understanding how esophageal varices form easier. So I'd revise that. Obviously, these patients are at risk of infection, so it's important to give prophylactic antibiotics based on your local formularies. Okay. So esophageal varices, first line, band ligation. If this doesn't work, then the patient can be considered for transjugular intrahepatic portosystemic shunt, or TIPS for short, procedure. This should be considered if first line band ligation doesn't work. Okay. If a patient has gastric varices, N-butyl-2 cyanoacrylate can be used first line. And again, if that doesn't work, TIPS procedure can be considered. So other things to have in the back of your mind, NSAIDs are a common cause of bleeding. So it might be worth stopping them. And if a patient's on any anticoagulation or antiplatelet therapy, it might be worth speaking to cardiology, whether the patient should be continuing this or whether it should be withheld. So speaking to somebody who's a specialist in that field to give you a bit of advice would be really useful. So we're going to talk about another scoring system now. This is a Rockle. There are two types of Rockle. There's a pre-endoscopy Rockle and there's a full Rockle, which is post-endoscopy. Don't get them confused. A full Rockle score is done post-endoscopy, and it tells you different things. So it's important to just know the difference. So a Rockle score is performed after endoscopy. It allows for assessment and risk of rebleeding and also patient mortality. Things that you need to assess in patients like this is the patient's age. So if the patient's older, they're at greater risk. Is the patient shocked? So these are signs that you probably be familiar with. So do they have a fast heart rate, a low blood pressure? Those are bad signs. Other comorbidities I'll just talk about in a minute. What they had a diagnosis on endoscopy, what did they find? And was there any evidence of bleeding? So you score 3 points if the patient has renal failure or liver failure, or if they have disseminated malignancy. And you get 2 points for any other comorbidity, a major comorbidity. Scores of less than 3 on the full Rockle have excellent prognosis, as opposed to scores of scores of 8, which are high mortality risk. So it's a useful tool for working out, is this patient going to, at high risk of mortality. Okay. So now, giving you a bit of background, we're going to apply the things we've just talked about to a clinical case. I'm going to ask some questions throughout. You don't need to say anything, just have a think in your head what you'd put for the answer, and feel free to put your answers in the chat as well. You're more than welcome to. So you're in AED, which is the Accident and Emergency Department. So a 65-year-old male patient presents with hematemesis. So he's been having pain just underneath his sternum. He says for the last few months, it's sort of been a niggling sort of pain. It's been getting worse over the last few days. The pain gets quite bad after eating. He also tells you he vomited a small amount of blood when he came in, and he's feeling a little bit lightheaded, but he feels fine. He doesn't feel agitated or anything like that. But he has got a bowl in front of him and he has vomited a little bit. This is his first vomit of blood today. So you decide to take a detailed history from this patient to get a bit more information from him. And before you do that, a nurse hands you his observations. So what would you be looking for on his observations in a patient who presents with hematemesis? So just have a little quick think and I'll read out some ideas that I had. Okay, so I was just checking the chat. Volume of blood, type of bleed. Is it bright red? Is it darker? Is it coffee ground emesis? How frequently have they been bleeding? How have they been vomiting blood for a number of days, weeks, hours? Has this happened before? Do they have known liver disease? Take a detailed past medical history from patients like this, including medication history. Are they on any anticoagulation, antiplatelets, or other medications that might cause hemorrhage? Remember to ask about alcohol intake and dependency. A patient might have a significant alcohol history and therefore be at risk of having esophageal varices. So that's what you want to be looking out for in the history. With regards to the observations, are they hypotensive? Are they tachycardic? Are they tachypneic? Are they alert or are they a bit more lethargic? So these are the patient's observations. So they're alert. The temperature is a little bit low, but fine. Respiratory rate of 18, a little bit tachycardic, and their blood pressure is a little bit low, maybe. We don't know what their normal is. It could be okay. And normal oxygen saturation. So what would you want to do next? So you'd want to do an A2E assessment now. Now you've got a bit more detailed history. You've done a preliminary set of observations. You want to start examining the patient now. So their airway is patent. They're talking to you. Their breathing is unremarkable. You auscultate their chest. You can't hear anything. Here are their blood pressure, BP. You decide to then put 2 large bore cannula in because that's part of the circulation, part of the A2E. For D, it's unremarkable. Okay, so we'll talk a little bit more about C at this point. So just giving you the answer there. But hopefully from what we talked about before, you would have got FBC, UNE, LFTs, VBG group and cross match. So you speak to your senior and they say that they would like you to fluid resuscitate this patient. So they want to give you some fluids to this patient. They have no past medical history of note that would cause you to worry about fluid overload. So have a think about what would you give to this patient? How would you fluid resuscitate them and what with? Okay. So if you said 500 ml of 0.9% sodium chloride over 15 minutes, that's a good choice. As always, once you give fluids, you assess their fluid status at that point. It's not good to just keep giving fluids to patients to a sort of lowish blood pressure. You want to see the physical effects on a patient. Do they suddenly become edematous and the blood pressure is not responding? So always assess a patient. So how would you assess a patient's fluid status? Have a think about some of the things on examination you'd want to look for. So there are many different ways of assessing fluid status, but two key points, I think, are auscultation of the chest and assessing a patient's JVP. So as we talked about before, D is unremarkable in this patient. So the nurse is doing some more observations on this patient now after this fluid bolus, and his blood pressure has actually dropped a little bit now. It's gone to 99/72, and he's a little bit more tachycardic, so it's 120. So, sorry, the patient becomes a little bit more lethargic now, and the vomiting a bit more blood. He's starting to become a little bit more concerned now that the patient's deteriorating. So at this point, you should be speaking to your senior. These are red flags that whatever bleed this patient might have, it seems to be getting a bit worse now. So when you were talking to the patient, they said they had long-term knee pain. What would make you concerned about this? What specifically about pain and chronic long-term pain might you be concerned about? Just looking in the chat. Absolutely, NSAIDs, brilliant. So a patient might be taking over-the-counter NSAIDs. They might be picking them up from the supermarket, and the doctor might not know about it. And the patient might not know the dangers of taking long-term ibuprofen or stuff like that, which puts them at risk of ulcers. So, simple things like that can have big consequences. So it's important to have elicited that from the history if you could. So moving back to the case at the moment. So this patient seems to be deteriorating. They've got the hypertensive tachycardic. We need to work out the risk and where this patient should be managed. So how do we do this? What scoring system would we use pre-endoscopy to work out this? So if you said Glasgow-Blattsford score, you're correct. So this is the scoring system that we used before endoscopy. And it tells you the risk of a patient needing medical intervention. So according to MD Calc, a score of greater or equal to 6 means that intervention is required in more than half of cases. Of course, it's dependent on each individual case. A score of greater than 0 means management outside the hospital should not really be considered, as they are a greater risk of needing intervention. Esophageal gastroduodenoscopy can be used directly to see the ulcer on endoscopy as a result of Glasgow-Blattsford score. So it really dictates where a patient's managed. So above 1, they really need to be kept in hospital. So what are some of the parameters that you would need to work out a patient's Glasgow-Blattsford score? So you might not remember because we went over it a bit quickly, but have a think about some of the things that you might want to assess pre-endoscopy. Yep, well, they have heart failure, hepatic disease, urea, HB, evidence of melena, brilliant. Yep, those are all important things. Okay, so this patient's Glasgow-Blattsford score is 6 points. So I'll just tell you that. Okay, so this patient is at high risk of needing medical intervention. So what investigation should be considered now?
So we suspect the patient's got an upper GI bleed. The high risk with a Glasgow Blattsford score. What should we be doing now? Yeah, endoscopy. So I'm not sure whether I explained this correctly earlier, so I'll just clarify. So what type of ulcer presents with a pain a few hours after eating? Duodenal, excellent. Okay, and that's not the same for gastric ulcers. Okay, so what are the options for endoscopic treatment of a non-varicose upper GI bleed? So there, on endoscopy, there were three options. Can you remember one or two of them? Yep, adrenaline and mechanical, plus or minus adrenaline, yeah. Okay. So when I say mechanical, I mean clipping, a bleed, adrenaline, thermocoagulation, or using fibrin or thrombin. As I said before, NICE don't really recommend just using adrenaline on its own. Okay. So that's just a little quick case just to go through some of the principles of management. As I said, the scope of this talk is just really about the acute management. Further management, I think you should have a look at yourself for some of the more specific causes, such as esophageal varices, but that's just a quick example. So some more questions. How does terlipressin work? Okay, so yeah, vasoconstriction of the splanchnic circulation, and this reduces portal pressure. So this is used in treatment of esophageal varices. What is a TIPS procedure? If you can't remember exactly what TIPS stands for, do you know what actually happens in the procedure? Just have a think. So a TIPS procedure, a stent is inserted, connecting the portal vein and the hepatic vein. And this is done to reduce portal hypertension. Again, remember, first line for esophageal varices and for gastric varices is other treatment. And then if that fails, TIPS is considered then. So talk me through some peripheral stigmata of liver disease you might find in examination. So if you examined a patient with liver cirrhosis, what kind of things would you find on examination? Yeah. So when you're inspecting the abdomen, you might notice ascites. They might be jaundiced. They might have caput medusa. When you look at their hands, they might have clubbing. They might have leukonychia. When you look at the palms, they might have palmar erythema. And there's many other peripheral stigmata of liver disease. This is really important, I think, at medical school to sort of get familiar with, because there's just so many. So those are a few of the important ones that you might find on someone with an upper GI bleed. Yeah. So that's all I wanted to talk about tonight. So we talked through the introduction. So what is it? Why is it important? We talked about the etiology of upper GI bleeds, the most important ones being those top three. Initial management, how do you stabilize a patient? using the A to E approach, making sure you correct things as you go along and always asking for senior support. Investigations, what bloods do you want to take? What scoring systems are used pre and post endoscopy? And then a little bit about the further management. So what specifically is done at endoscopy to help fix it? And if a patient rebleeds, interventional radiology or maybe surgery may be required. So that's everything that I wanted to talk about.